Hello, everyone, and welcome to another webinar through IHN. Today, we are having our webinar with Dr. David Duizer. Did I say that right?
You did.
Okay, good. Yay! I'll just start by introducing myself. So my name is Inder. I am part of the administrative team at the Institute of Holistic Nutrition. I do things like student clinic and continuing education as well, a bunch of other things, but I'm part of the administrative team and I'm always here to connect with students. Tonight we have a webinar with Dr. David Duizer for his course, Understanding Lab Diagnostics and Clinical Practice. The webinar is called Lab Diagnostics in Cardiovascular Disease Risk Management, Preventing the Silent Killer. So I'm going to just talk a little bit about Dr. David. So he is a naturopathic doctor with a special interest in the holistic approach to cancer, cardiovascular disease, diabetes, and autoimmune disease, His clinical focus is to address the cause of disease and support the body's ability to heal naturally. Through advanced laboratory testing and the use of nutrition, lifestyle modifications, herbal medicine, orthomolecular medicine, intravenous therapy, physical medicine, Dr. Duizer aims to reduce symptoms and reverse the disease process. So I'm going to pass the screen off to Dr. Duizer, where he will talk to you a little bit more about the course and maybe introduce himself a little bit more, because there's a lot to know, and I will see you guys all at the end.
Thank you for a very kind intro, Inder. Welcome, everyone. Thanks for attending. I hope you can hear me well. We are all set. Okay, I'm straight. I've got my power on. I'm ready to go. Thank you so much for IHN for having me this evening. I love giving sessions about integrative medicine and holistic medicine, and this is a real joy for me to be here, so thank you very much. To build on the intro just a little bit, I have a couple things that I'm really passionate about that are rather new in my practice. One is that I do physiology, exercise physiology in the practice. So we do VO2 max assessments, which I think is the heart piece that will be missing from this evening's session. That is really important, but it's a functional piece and less of a lab piece. So, but we can maybe chat about it at the end if you have some questions about the exercise assessments in heart health. The other thing about me is I'm really passionate about this industry as a whole, and I'm the vice chair of the Canadian College of Naturopathic Medicine. It's a role I absolutely cherish. The promotion of the academics in our field is very important to me, and so that's where I spend my time volunteering is with our institution. With IHN, I've been teaching lab diagnostics for a very long time now. I think this may be my fourth time. I'm not sure. It's an awesome course. I love teaching it. I think it's really important for nutritionists to take for so many reasons. The key reason, this is what I tell students on the first day, is that we all need to be able to talk the talk. We all need to be able to communicate with each other about what's happening in front of us. So if you're working in an interdisciplinary clinic, okay, you need to be able to talk with everybody in the clinic about what you're experiencing, subjectively, objectively. On the objective side, the labs are a huge piece. On the literature review side, you want to be able to be comfortable while you're reading studies. And in order to be comfortable, you have to have had repetitions. Lab diagnostics is just repetitions. We don't memorize any reference ranges. We don't necessarily memorize the differential diagnosis that you would be making when evaluating a lab. We just get comfortable with as many labs as possible for the time that we have, so that when it comes up in your real life, you have an opportunity to say, oh, I've seen this before. I know exactly where to look. I've got the book. I know where to look online. I've got David's slides. That's what I'm trying to facilitate with this course. So Inder will be talking a little bit more at the end about the upcoming course. And today what we're going to do is take my favorite snippet from session 1. Session 1 is Intro to Lab and Cardiovascular Disease. So we're going to jump into a snippet. I've deleted some slides so that you're just getting a little taste of what the course is going to be like. But I'll say that this is, from a rational standpoint, some of the most important slides, some of the most important exposure that you'll have, because cardiovascular disease is #1 killer of Canadians. So if we're talking about nutrition programming and we're trying to prevent death and help people feel better longer, we need to know how to evaluate the heart and blood vessels so that we can program effective nutrition plans to support their optimal well-being. So I see this as being like #1. This is why it's session 1. Not only do I love talking about it, but also it's like ridiculously important for us. And not many people do this well. Not many people are able to evaluate labs, make suggestions for what labs could fine-tune the treatment protocol. Because the only real reason to do a lab other than to assess for disease is to say, should we change the protocol or not? If a lab points us in the direction of requiring change, that may have been a very helpful lab for us. So this course tells us which direction we should be going, or which direction was chosen to facilitate what plan. And then as a holistic nutritionist, you get to be a key part of the plan. I would suggest the most important part of a heart healthy plan. So if you can't tell already, I love it. I've been chosen to speak at conferences about the tests we're going to review today. I've written for Vital Link, the Naturopathic College, Naturopathic Journal, about the labs that we're covering today. And so I've been thinking about this for like 3 or 4 years and have been chosen to present on it multiple times. So it's a pleasure. Anyways, I'm glad you're here. Side note, we're going to be choosing a winner for the giveaway today. I have a supplement company. That's my only disclosure here, is that I have a company called Noble by Nature, and we have a series of products, and one lucky winner today will get a series of products from us. So that'll be chosen at the end, so you got to stick around. Can't hear you.
Sorry there. I'm just going to add 2 things here. So I'm going to be choosing a winner at the end. However, you have to stay till the end in order to receive that prize. So if you're not here, then we will choose someone new. And then the other thing is if you have any questions throughout Dr. David's presentation, please pop them into the Q&A box, and then we'll answer them at the end. And that's it. I'm going to turn my screen off, and it's all yours.
Perfect. Okay, let's do it. Here we go. So a snippet from session 1 of Interpretation of Lab Diagnostics in Clinical Practice. Let's go through it. So why do we want to understand labs as a nutritionist? Well, basically what we want to do is make nutrition programs that support optimal outcomes. But in order to support optimal outcomes, you need to know what is the cause of atherosclerosis, cardiovascular disease. What is the driving factor that would require nutrition change? And we know that 50% of cardiovascular events like strokes and heart attacks are associated with elevated LDL, which we'll review today. But what about the other 50%? We need to learn what they're associated with. Here's how I got here. This is a bit more of my bio. We've talked about this a few times. Okay, so coming up, my course, Lab Diagnostics. All right, so let's consider this as part of a session in continuing education. Why are we doing continuing education? The only reason I do continuing education is to improve my ability to help people. That's it. That's the key. That's the core reason. And I choose the courses that I'm going to be attending to facilitate that purpose. Okay, so I want to help as many people as possible in the most effective way possible. So I choose courses that make that happen. If that's your reason for doing continuing education, Lab Diagnostics would be a great one to take. In session 1, we cover we cover functional assessments and a systems approach to lab review. So objective review of body function and body systems as a whole. And we talk in that session about those two topics and how they might relate to your practice. But for today's purpose, we're going to go right into the cardiovascular assessment. So let's jump into that. I've reviewed some of this already. Why do we do labs? Here we go for cardiovascular disease. So let's start with the title of a study from the journal Nutrients 2018, Contrasting Effects of Short-Term Mediterranean and Vegan Diets on Microvascular Function and Cholesterol in Younger Adults, Comparative Pilot Study. The reason I put this slide on here is just to show how the course that we're going to be doing in the next few weeks actually facilitates nutrition programming. So we review things like this study, where we would be looking at microvascular function. What's happening in the microenvironment of a blood vessel? And what are some cholesterol metrics that we might be wanting to measure if we're doing different diet therapies? So this is a comparative pilot study, but it just shows that there's interest right now in evaluating nutrition effects on lipid biomarkers. Today, we're reviewing what those biomarkers are. But, they're always trying to see, is there some other diet that might be better than the Mediterranean diet for heart health? And in the course, we dive into that. Love it. The conclusion they found in this study was that the Mediterranean diet led to improvements in microvascular function, and the vegan diet led to reduced total cholesterol and weight loss. Although both diets might offer cardiovascular risk reduction, evidence for the Mediterranean appeared to be stronger due to changes in vasodilatory ability and nitric oxide bioavailability. So cool. This is the absolute nitty gritty. So we talked about LDL cholesterol. We'll review what that is in a second, being associated with 50% of cardiovascular events. Well, do you know how many Canadians that actually is? That's a huge number, which is why LDL suppression is a big part of conventional care. Where I think we can have influence in the integrative space is in those other 50% of cardiovascular events. Is it inflammation of the vessel causing hardening, reducing the vessel's ability to dilate? Is it blood sugar driving damage to the vessel, reducing the vessel's causing plaque buildup in the vessel, initiating that process of a formation of a clot? Is it some genetic risk? Is there a lipoprotein, for example, that could be driving the buildup of a plaque in a vessel not related to LDL? What are the things that might lead to microvascular dysfunction? And are there nutrition programs that can reverse these? So when we talk here about the Mediterranean versus vegan diet, we think about the fact that this study showed that when people were eating the Mediterranean diet, the vessels were a little more flexible. They had a better vasodilatory ability, and that is made happen by nitric oxide. So the nitric oxide was more bioavailable, which created more flexibility in the arteries. Even though the vegan diet had some other benefits like reducing total cholesterol, that didn't tell the whole story. So for this other 50% of people, hey, wait a minute, we can make the vessels more flexible if we use this nutrition programming that is so easy to actually do. Here's one more. Low-calorie vegetarian versus Mediterranean diet for reducing body weight and improving a cardiovascular risk profile, the CardiVeg study from 2018, published in my favorite journal, Circulation. My favorite one. If you've never read it, go and read it, please. This was a randomized control trial. Amazing. What they found was vegetarian diet, Mediterranean diet were both effective in reducing body weight, body mass index, and fat mass. No significant differences on those objective markers. However, vegetarian diet was more effective in reducing LDL cholesterols, whereas the Mediterranean diet led to greater reduction in triglyceride levels. Triglyceride, another type of lipid that we're going to be reviewing a little bit later. So another way to illustrate that, nutrition research is being done, and in order to read it, you need to know about the biomarkers that we're going to review today. In your practice, you probably see a lot of this: high cholesterol, high triglycerides, stiff vessels, high blood pressure, chest pain, a history of stroke and heart attack, and a family history of stroke and heart attack. You see these. So what are you going to do about it? What you're going to do is help them eat better and make sure that the markers that are being tracked are being improved. One really, really good example of this is helping people come off of statin therapy. I'm sure that if you're working in a primary nutrition providing, or if you're considering working in optimal wellness, primary care, nutrition programming, you're going to be helping people who have high cholesterol, who are already on statins. And there are so many simple changes that can be made that reduce the need for statins. You're going to have to be present with the person and help them understand when it's time to have that discussion with their doctor about either reducing the dose or coming off completely. Because nutrition really works. It's really effective. So let's say we're working in primary prevention. That means primary prevention means someone has not had a heart attack or a stroke before. Okay, but they have high LDL cholesterol and total cholesterol and maybe even triglycerides. They're on a statin medication, probably a good drug for them. Maybe I'll have time today to teach you how we know if it's a good drug for them or not. But let's consider the fact that the reality that it probably is. When they reduce their total cholesterol and LDL cholesterol and triglycerides, the absolute 10-year risk of a cardiovascular event is then reduced. But what we need to know is we need to know by how much, so that we can say, you have gone from this amount to this amount with the medication, and the nutrition has brought you to this amount. No other changes in medication, only nutrition therapy. Now, because you know about LDL and triglycerides, you can say, listen, these have come down even more once you started this nutrition plan. Hey, wait a minute. Maybe we have an opportunity now to then reduce the medication. Not that we'll be doing it, but maybe the doctor will be more interested. And the way of actually knowing how to recommend this when you tell a person to go back to the doctor is by knowing when the actual risk of too much reduction in LDL has taken place. It's actually very, very common. So there are times when LDL cholesterol should be really, really reduced by statin medication, but there are also many times when it's too reduced. And you see things like memory loss and fatigue, foggy brain. Something to consider. In order to actually evaluate it, you need to know about labs. So let's talk about a systems approach to cardiovascular disease, because I think this is like literally the most important way to think about this. The systems approach is understanding what factors are occurring functionally in the human body that lead to a plaque buildup that is vulnerable for rupture. So I hope that makes, like, that one long sentence that I said actually makes sense. Plaque builds up and then has a risk of rupturing. It can build up to the point where it crosses. If you can't tell, this is a blood vessel. The plaque is the yellow. It could build up, and then plug the whole vessel. Yes. It could also build up, and then release from the wall and travel to a smaller vessel and then plug it. This slide was actually taken from the protein unstable lesion signature test that Life Labs offers. This is a really cool test because it's a test that takes into account more than just LDL and triglycerides. It takes into account 10 different biomarkers, 8 of them being increased in a chronic inflammation scenario. So you can see the headlines here, not that you need to know any of these, but the headlines are suggesting that the body is responding to the vessel in a way that is supposed to heal it, but for some reason it doesn't. So why does the vessel need to be healed? Well, it could be damaged by high blood sugar. Diabetes is associated with worse cardiovascular outcomes. It could be damaged because of oxidative stress. a toxic environment, potentiated by obesity, potentiated by environmental toxic exposures. It could be damage from chronic hormonal imbalance, like stress hormone imbalance. Chronic stress can lead to negative cardiovascular outcomes and stiffer vessels. There are many reasons why the vessels can be injured. One thing that happens when there is an area that is either injured or inflamed is plaque will begin to build up, and a key part of that plaque is cholesterol. Another key part of that plaque is minerals like calcium, which is why they use a coronary calcium scan to evaluate vessels. So when I say the systems approach, there's a lot that goes into blood sugar control. You need to have muscle. There's a lot that goes into detoxing environmental toxins. You need to have a healthy liver and digestive tract and kidney function. There's a lot that goes into the hormonal maintenance, the hormonal homeostasis that prevents stress hormones from going extremely out of balance for prolonged periods of time. And there is one response that is very key in reducing the impact of LDL in the body, and that's the release of HDL by the liver. So thinking systematically, the liver has to make this thing called HDL when LDL goes up so that it can be recycled more effectively. So you can see what I'm saying by this is like a systems approach. We have to think about stress and blood sugar control, muscle mass, digestive function, liver function, kidney function. We have to think about consumption. We have to think about our approach to sleep, stress management, in order to facilitate a healthy heart long term, with the goal of preventing plaque buildup and rupture. So the most common lab you'll see in practice is something called a lipid panel. A lipid panel includes the first 5 bullet points here, not the 6th. The 6th is a bullet point you have to do on your own. It includes total cholesterol, LDL cholesterol, HDL cholesterol, triglycerides, and then a ratio, total cholesterol to HDL. It's such an awesome test. It's really, really awesome. When people get to the age of 50 and haven't had this done before, I am so surprised. It's the most common lab other than a red and white cell that we see in clinical practice. This is usually done on everyone who's ever come into our practice has had this done at least once in their life. If you haven't had this done, gosh, it could be interesting to see, because cardiovascular events affect Canadians of all ages. So don't think that this is a test for the elderly. It is not. It is a test for everybody. And in fact, cardiovascular disease is occurring in younger and younger populations all the time. And maybe today we'll have a chance to talk about why I think that might be happening. We're going to go through all of these, but first we should start with a case in order to actually facilitate this. John is a 28-year-old male. John is not a real person. John has high LDL and also very high HDL. So what that means is the liver is making a lot of this protein called LDL so that it can package up these little molecules called cholesterol to transport them to the tissues. So on the lab, the LDL looks quite high. And that is actually because there is a lot of cholesterol being distributed to the tissues. Now, at the same time, because a lot of cholesterol needs to be distributed, the liver has to make a lot of HDLs to facilitate the recycling of the cholesterol. So the HDL cholesterol is high too, because it's effectively clearing the high level of LDL cholesterol. And so the total cholesterol actually looks pretty high, but the risk ratio, total cholesterol to HDL, is not too bad. This is a very common thing that you'll see in practice. I saw one today, to be perfectly frank with you. The total cholesterol to HDL ratio should be below 4. Today, I saw someone with an elevated total cholesterol and an elevated LDL cholesterol, and also a very nice HDL cholesterol, and therefore their risk ratio is fine. They're probably watching this right now, and they know they know them if they're watching. They know themselves. So very, very interesting that the body can respond when it feels like it needs to package up a ton of cholesterol. It can do so. So let's go through some of this. So this are the things that are found on the lab. If you've ever seen this, typically the labs that we're using here in British Columbia would be Life Labs, but we also send labs to a place called Dynacare. All across Canada, there are hospital labs and other private labs that can run this exact same test. All the labs and different regions, so same lab, but different region will have different reference ranges. So don't worry about the actual reference ranges, because they'll be different between labs. So when we think about total cholesterol, the first number that you see on the typical lipid panel, here's what you need to know. Cholesterol is a very, very important molecule in the body. It is helpful. It's used to make all of our cell membranes. So our cells are constantly turning over, and that process depends on a healthy level of cholesterol. So we should not go for net zero cholesterol. Absolutely not. You have to have some. One of the main reasons people come to me to talk about their cholesterol is because it's used to make hormones. So if people are looking to optimize their hormones, they have to have enough cholesterol to do so. When cholesterol is suppressed too low, there's a risk that hormones might not be made effectively. Total cholesterol is highly variable. You can see that level there, that change there, 15% day-to-day variation. Then we have triglycerides at the very bottom of the lab. So we're covering the top and the bottom. Triglycerides are that immediate source of energy. Triglycerides can be used to make energy when the demands are not terribly high on the body. So when the demands are high, we tap into our free circulating carbohydrates and our stored carbohydrates. But when the demands are low, we can use this form of lipid. And it's made up of a glycerol backbone and 3 fatty acids. And if they're not used for energy, so if a person has high triglycerides but doesn't exercise, they're then stored in the fatty tissue, and they can cause significant inflammation. Generally, when a person has more fat on their body, they have a greater level of chronic low-grade inflammation. It is a very changeable number. You've probably heard of a lipid test, some people going for this test fasted and other people going for it fed. And that's because when you eat before this, the triglycerides could look a little higher than if you didn't. So it doesn't matter that much, but if you're being very specific about triglyceride management, fasted is better. Oh, and it's very changeable by activity level. Isn't that so interesting? It's used for fuel. Exercise the day before a test can decrease by as much as 30%. Wow. Then we have HDL. This is an important one to review next. HDL is the lipoprotein. It is the protein made by the liver to distribute the cholesterol. But what you're seeing on the lab is not the actual lipoprotein. What you're seeing on the lab is how much cholesterol is actually in it. So what they do is they take the blood work and they crack them open and see how much cholesterol is actually in them. There you go. Generally, it's measured. Some of these labs are measured results, but when you see it on the lab, it's actually referring to how much cholesterol is in the lipoprotein. We'll talk about actually measuring the protein a little later. HDL lipoprotein is preventative against cardiovascular disease because it is the recycling protein. It's the one that goes around and scoops up all that extra cholesterol that you didn't use to make hormones and cell membranes. So HDL, very, very important. The main thing that increases it is exercise. You can artificially increase it with niacin, but niacin doesn't change outcomes. So it is generally accepted now that the consumption of niacin for the purpose of increasing HDL does not reduce mortality. Then we have the big goblin in the room. The big goblin in the room. This is the key reason why most of the people that you are seeing who are taking statins are actually doing so, because they have high LDL cholesterol. This slide and the previous slide should actually say low density lipoprotein full of cholesterol, because it's the cholesterol that's trying to be managed. This is the one that transports the cholesterol from the liver and takes it out to the body to be used. Now, it can get stuck. The actual cholesterol that's being transported can get stuck. And the protein on its own is actually atherogenic. So separate these two for me. Keep it very simple. The protein transports the cholesterol. The cholesterol is used to make cells and hormones. The cholesterol can get stuck in plaque. The protein is also very sticky, and on its own is an independent risk factor for cardiovascular disease. So generally, when a person is taking a medication to actually reduce their LDL cholesterol, the key effect is that there's less cholesterol that needs to be packaged, and therefore less of the protein is being made. And we know that this is the key function. And I'll talk about APOB100 in a few minutes to further elucidate this point. So we have found out that a person has high triglyceride, or high, remember the case, total cholesterol, LDL cholesterol, and HDL cholesterol. What do we do? Well, in this scenario, they have a normal risk ratio. Their total cholesterol to HDL is perfectly fine. So that's good news. That means that this part of a cardiovascular risk assessment is not driving risk in a significant way for most people. So there's so much nuance in that paragraph that it can be a little bit confusing. We know what biomarkers increase cardiovascular risk: blood pressure, smoking status, diabetes status, and age, and gender, and cholesterol. So you see how I add cholesterol at the end there? There's so many other things that increase the risk. Let's talk about the case at hand. High LDL, high HDL, high total cholesterol, normal triglycerides, low blood pressure, exercises, doesn't smoke, and has perfect blood sugar control. Oh, we plug in all those numbers. Guess what? Their risk of a cardiovascular event in 10 years is less than 1%. So we use the Framingham calculator to do that. We use ASCVD calculator to do that. These are things we review in the course, and we do tons of cases to actually elucidate this point so that you can, on the next day after you take that class, you can do it in front of your client for them to say, I want you to do a Mediterranean diet because you have a moderate risk over 10 years. If you do the Mediterranean diet for this amount of time, your risk will no longer be moderate. It'll likely go down to the low risk category. Those are the outcomes that I want my students to help facilitate. So we talked about the cholesterol that is actually in these proteins, but I left you hanging and I said that there's something called ApoB. Check this out. Where is it? ApoB. It's way down here. Is it even on here? Maybe not. ApoB is a measure that is done at our local lab. And here it is. No, it's not on there. ApoB is a molecule that is attached to every single LDL protein. And it can be measured very inexpensively. That tells us how many particles. I've taken us one step further here and actually measured the particles. Look at this. This is a sample result of LDL-P. Do you see that at the top? LDL particle number. In Canada, we typically test APOB100 because it correlates exactly with the particle number. And guess what? That is more helpful than actually how much cholesterol is in these proteins. How many particles there is in a sample of LDL is a little more helpful than knowing how much cholesterol is in them. And so you'll see when someone brings in their lipid panel nowadays, it has all the things we just reviewed plus APOB100. A lot of family physicians in our neighborhood do this test because they see the value in it, and it changes treatments slightly. So a more detailed test would be the NMR Lipid Profile, because it actually does how many particles of LDL is in there, how many particles of HDL is in there. It's closer to the bottom of the slide. And how many of those LDLs are small and dense and super sticky. See where it says small LDLP, 533 high? Okay, that's what an NMR gives you. It tells you, okay, they had high LDL. We knew that from the Life Labs test. But how many proteins were in that sample? Okay, here we go. LDL particle, that's the number of proteins. Wait a minute. How many of those proteins were small and super sticky? That's that test. That's the NMR. Now, the reason this isn't common practice in our region is because it doesn't really matter how many of these proteins are small and sticky versus how many are large and fluffy. If there is a lot of them, it's a sticky situation, okay? So they just test ApoB, and if it's high, they suppress it. And we have very rarely seen, we run this test quite a bit because people request it, and I think more knowledge is better. So we run it. And very seldomly, maybe only twice in my whole career, has the small, sticky LDLs been elevated and the total number of LDL particles not been that high. So you have the idea. You see the lipid profile. You take an extra step by saying, I know what ApoB is. Have we seen that one? If we have seen it, okay, maybe we got a little bit better information to work on reducing the stickiness. But wait a second, only 50% of events are driven by this. So there's 50% left over. We need to personalize. We need to personalize our assessments. These are things, if you work in offices or collaborate with practitioners who have this type of obsession that I have, you'll see these tests. You'll see the omega check. Why will you see the omega check? Omega-3 suppresses triglycerides. When triglycerides are above 8, clinicians can use a medication to suppress them that is omega-3. So generally, we use a lot of omega-3 in heart health. Now, there's one caveat which we have to review in the course, which is that omega-3 at high doses can cause arrhythmia if used improperly, or can be associated with the onset of arrhythmia. So it's not just like everyone with high cholesterol should take omega-3. Absolutely not. Maybe we need to test. What about vitamin D status? Vitamin D is a very important vitamin for immune responses and healing. And we're talking about healing. We're not talking about cholesterol. We're talking about a vessel that is not, it's like the wound that doesn't heal. It's injured, it's getting a little stiff, it's getting a little sticky in there, and something bad could happen. Vitamin D plays a big time role in cellular repair, and it's the only thing Health Canada thinks we should all be taking because Canadians are so deficient. What about vitamin B status? Vitamin B status is something you can see when doing a heart assessment. Why? Because if B12 and B9 are low, something called homocysteine can go high, and it damages vessels. Well, what about the elephant in the room here? Inflammation. Inflammation happens for a reason. Think about a sprained ankle. It swells up, and you tie your shoes so it doesn't swell too much, because swelling too much can increase the risk of scar tissue formation, maybe worse outcomes, maybe. What about a wound that you never have an opportunity to tie the laces tighter? Or something where you picture someone spraining their ankle every single day. Deep fried food every single day. High blood sugar every single day. Toxins from alcohol every single day. Toxins from cigarette smoke every single day. That means chronic low-grade inflammation. Doesn't matter what their cholesterol is. There's going to be inflammation in the vessels. And that inflammation can increase the risk of a negative event. We'll review the pulse test in a bit. I already showed you one of the slides. CRP, C-reactive protein, we need to review. Then we'll go through genetic risk, and then we'll talk a little bit about blood sugar control. Maybe not today, maybe we'll save that for the course. Okay, so we have a 40-year-old male who drops dead on the soccer field. What the heck? This person played soccer since they were 10. They played in college. They played high level. They were extremely lean and they were extremely fit. Well, what the heck happened to Dave? What happened? He didn't have high cholesterol. But Dave had a problem in the vessels, and that problem led to plaque buildup, or at least some clot formation that had a potential to travel. You might know the term LP little a or lipoprotein A from the first place I was exposed was, I believe it was Bob Harper on The Biggest Loser. I think it was The Biggest Loser. One of the trainers had a heart attack very young, and I think I'm getting my story correct by saying that they ended up having high LP little a. This one is genetically coded. It causes an increased potential for clot production to be distributed to the aorta. So it looks just like LDL particles, but it's not called LDL. It's called lipoprotein A. And genetically coded, very difficult to change the level. Medications are in the works now. We don't use them here. What we do when we find that this is increased is we take all of the rest of the things more seriously. We consider the actual risk of having this genetic predisposition to cardiovascular disease, and we say we need to have the best blood pressure on the market. We need to have the best blood sugar you've ever seen. We need to have the best lipids that we have optimal levels on lipids. And then, of course, we like to talk about optimal levels a little bit. So it's genetically determined, and it doesn't respond to strategies very well. I haven't had a lot of success with it. But it increases the risk of stroke and heart attack. That's what it looks like. On the left-hand side there, you have your LDL, and you have the ApoB attached to it. And on the right-hand side, you've got the LP little a. It consists of an ApoB. Hey, wait a minute, wasn't the ApoB? The protein portion of LP little a consists of an ApoB, a protein that's involved in the breakdown of lipids. Hey, wait a minute, there's an ApoB. It has an ApoA. A second protein component, which is attached to the ApoB and has an unusual structure and thought to inhibit clots from being broken down normally. ApoA might prevent clots from being broken down. So remember back to our test, we could test ApoB and get a good sense of if the cholesterol was normal and the ApoB was high, maybe there's something driving that. Some more information that we'll review in the course. Then we have fibrinogen. Fibrinogen is a protein that is in the plasma that's broken down to fibrin by the enzyme thrombin to form clots. So if someone's in a scenario where, oh my goodness, they're making some clots quite quickly, fibrinogen could be tested and it could be discovered. Here are some conditions where fibrinogen is elevated. So not necessarily high cholesterol, but say someone has a deep vein thrombosis forming that could then travel to the heart or lung. Fibrinogen might be elevated. And if you see that on a lab where they've done lipids and then they've done, say, ApoB, and then they also did fibrinogen, you want to know what that is and why they're doing it. It's an acute phase reactant, and that means that it can be elevated in a bunch of different scenarios. And guess what? All of these scenarios increase the risk of a cardiovascular event. Look at the bottom one, inflammatory conditions. Autoimmune diseases increase the risk of a cardiovascular event independent of their cholesterol status. Why? Because inflammation can cause problems long-term, but fibrinogen could be tracked. Okay, we've got another case here. Joe's a 34-year-old male who tested his lipids and his NMR, eats very, very poorly and has low B vitamins, and his homocysteine builds up. Homocysteine, it's right there in the middle of the page. I don't know if you can see that. but we've got a couple biochemical processes occurring here. And you can see on this page the words vitamin B12, vitamin B6, and folate. These are important in the metabolism of methionine. It's an amino acid. If it's not being metabolized properly, homocysteine will build up, and you'll get less cysteine, which means less antioxidant status, and it ends up being a problem. Homocysteine, bad, bad, bad. Then we have CRP. You may have seen CRP on a lab before. It's again an acute phase reactant, just like fibrinogen. CRP goes up with inflammation. But guess what? Low-grade chronic inflammation. So a CRP that's just slightly elevated can be a good sign that there's a risk of something bad happening in the arteries. So it can be tracked very effectively. It's an awesome test to be using. And then we have LPPLA2, lipoprotein-associated phospholipase A2. It predicts atherosclerotic disease. But what is it? What is it? It's an enzyme produced by macrophages. So where do macrophages come from? They come from the inflammation cascade. Macrophages recruited, they release this enzyme, and you can measure this enzyme. You might see it. It's getting more and more popular. We run it through the Cleveland Clinic. Strong association with this marker and coronary heart disease and stroke in the general population. Baseline elevated LPPLA2 associated with increased risk for restenosis after a stent. So someone has a stent. A stent, if you're not familiar, is something they put in after there's a blockage in the heart. But if there's still inflammation happening in the vessel, I like this one because it's more specific to the vessel, whereas CRP is not specific to the vessel, but still associated with worse outcomes. This one, specific to the vessel. Because remember, it's just coming from those macrophages that are in the vessel. If someone has metabolic syndrome, so prediabetes, we should know if they're inflamed. We should know if they're inflamed in the vessels. It's actually very valuable to know. And we've known since 2007. That's when that one was published. But that's not all. There are other tests that can be done. You might see the pulse test come across your desk. You might see this. It's getting to be more popular. LifeLabs brought this in a few years ago, but it's been in the marketplace for over 20 years. You'll see some things on there you might actually be familiar with. HDL, we've talked about it. Remember, high is good for HDL. Hemoglobin A1C, the bottom right there, the red, that one's on there. Why? That's the average blood sugar over 3 months. Higher, worse for the heart. But the rest of these you probably haven't seen before. SFAS, IL-16, MCP3, CTAC, fast ligand, HGF, and eotaxin. Very, very interesting tests. They give a 5-year risk. So if we're looking at lipids and thinking about blood pressure, diabetes status, and smoking, we can give a 10-year risk and feel pretty confident with low, moderate, and high risk categorization of people. Remember, that's not just LDL. We're also thinking about blood pressure and diabetes status. But it's a 10-year risk. What about a 5-year risk? Well, this one gives us a 5-year risk. And if you see it in your practice, you should know what to do with it. We talked about the omega check. We've seen a ton of different labs today. It's a crash course. It's a fast review of these. What are we going to do with them? Well, for one, we're not completely done. For one, we need to know about the systems approach. And that's how we complete this 3-hour session for cardiovascular assessments. During this 3-hour session, we talk about hormones, stress, sleep, and their impact on the heart. We talk about critically evaluating labs and building up encouraging follow-up plans, evaluating our nutrition program. For lipids, every 3 months. For everything else, quicker evaluation could be better. CRP is a good example. We know that certain interventions that are considered holistic or integrative or on the natural side of things can lower CRP in 30 days. We need to know what those are and how to apply them so that we can then say, please go ask for an assessment in 30 days. See if that inflammation is down. Here are some of the references from today that you can check out. I like reading through the Cleveland Heart Lab documentation for lipid assessments. If you're really curious, just go to the Cleveland Heart Lab page and read everything they've written. We have 8 minutes to go. What a great time for some questions. I'm just having a look at my notes to make sure there's nothing I didn't actually, there's nothing I missed. How to effectively communicate with clients about their heart health. I want to say something about this. How do I get out of my thing? There we are. People are going to come to you and say they want to. People are going to come to you and they're going to say that they don't want to take their medication any longer. But you and I, we need to be effective at saying why we think it's good or not. It's not enough to say, that statins are bad. It's not enough, because sometimes they're good and we need to know why. And so this is really why I like talking about this, because if you take this course, if you go through this in detail, you get to know why. Why are they good in some scenarios? How good are they? How much good are they? How much % risk reduction will we get from them? And if the nutrition plan really is effective, it works, hey, medication is not forever. What a win. But we need to know how to evaluate the labs to say if it's working or not. So you got to be able to talk the talk. That's why I love this. Thank you so much for listening. Let's answer some questions. Okay, should I just have a look at them, Inder?
Yeah, so David, I was just going to ask you if you want me to read them out to you or if you wanted to take a look at them. And then
I can read them. Read them.
Okay, sounds good.
Yeah, I see I'll just go in order.
Okay.
How would you support a 65-year-old male with previous cardiac event with good lipid numbers, healthy diet, who wants to come off beta blockers? Okay, so I can't give you medical advice here today. How would I support them? It's a complex question because we need to know what the physician is thinking for the actual use of the beta blocker. What are they trying to accomplish? So usually after a cardiovascular event, they do cholesterol suppression and blood pressure control and beta blocker and blood thinner. And sometimes they'll give a timeline because it's been shown to improve outcomes. But if it's outside of that timeline and there's no real reason for continuing based on what the team suggests, then we can support. So beta blockers lower the heart rate. And so you need to know why they're lowering the heart rate in that scenario in order to do that. So unfortunately, I can't really answer that one because it's so individual. It's an awesome question that with more information we could review in the course if you want to bring it, please. And I'll tell you what I typically do. Please name the test from Life Labs that looks at the 10 different biomarkers. The pulse test, protein unstable lesion signature. Is the LDLP a measure of the small dense and large dense LDL? Small dense and large fluffy. But yeah, large dense. Yes, it's a measure of all of them. So LDL particle is adding up all the small and large LDLs. Great question. Please indicate the optimal number for APOB. Okay, so APOB100, when we're assessing it, if there's a moderate or a high risk, we go for decimal 8. But if they're at low risk, I think just being in the normal range is fine, less than 1.2. How much vitamin D3 should be recommended for adults to take? Without a test, 1,000. that's what I feel comfortable suggesting in a setting like this. Individually, we individualize plans for people. We test vitamin D and we see if it needs to go up faster, and then we give more. But I think Health Canada wants everyone over the age of either 40 or 50, I'm not sure what that number is, to take 1,000 IU per day. And we give our kids 400 IU. Okay, and then I see there's something in the chat. Thank you very much. I learned a lot already tonight, especially that there's so much I don't know yet. Thank you for this. Oh, that's a really kind comment. Thank you for the comment. Any other questions today? Oh, you're welcome. Join me for the course.
Yes. Thank you, guys. Thank you, everyone, so much for being here with us tonight. It was wonderful to see so many people come in. We will end this session shortly, but we do have a few things we have to do. So the first thing is Dr. David's course is starting February 8th, so it's very soon. You can email us at instituteofholisticnutrition.com. You can check out our newsletters and you'll be able to see Dr. David's graphics up there, and just click links and you can sign up that way. You can call us at the school as well. So there's many different ways that you could register for the course. It's 7 sessions long from 6 p.m. to 9 p.m. Eastern time. And again, it's the Understanding Lab Diagnostics in Clinical Practice. I will announce the winner of the prize. So the prize is, sorry, let me just pull it up here. So I can just read out to you exactly what you will be winning. So one lucky winner will receive an immune support supplement pack from Noble by Nature Premium Supplements. This is Dr. Duizer's personal brand. It includes vitamin C, zinc, and vitamin D3. So the name that came up was Stacy Tolles. So yay! Yeah, so Stacy, if you're here, can you just say I'm here in the chat?
And don't leave yet, everyone. I want to put my email on here. I'll put in my email.
Yeah, exactly. I'm gonna just do this part, and then I want Dr. David to be able to wrap up and say a few more things.
Oh, Stacy's here. Hey, way to go.
Okay, awesome. So we'll send you out an email and more information about your prize. Congratulations. So thank you all so much. Dr. David, you can...
Yes, I put my email in the chat. If anyone would like to connect, if you have any questions for me about today's session, please email me and I'll get back to you. My practice is called Noble Naturopathic on West Broadway and Spruce Street in Vancouver. If you ever want to stop in and say hi, you can. And, oh, you can't see the email? In the chat. Here, I'll just send it to you again. Send to. Here we go. Stop in and chat. If you ever need anything, have any questions about what we're doing or any of the labs that we saw today, please feel free to reach out. Great. Thank you.
Awesome. Bye, everyone.